Al-Haram Hospital, Giza, more than 3,500 cases of eligible applications done yet. Head of Orthopedics Surgery Department, Benha University Hospital, Al Giza, Egypt. Ex-president of Egyptian Orthopedic Association, ex-president of International Asami and Bone Reconstruction Society, and is co-chairman of Scientific Committee of EPOS, member of Education Committee of SICOT, ex-president of Assam, Egypt, editor in Journal Children Orthopedics, member executive board of editors of Egyptian Orthopedics Journal, and editor Scientific Journal International, and editor in Pediatric Orthopedic Journal Part B, and has so many publications. So with this, I request Gamal sir to share his presentation.
First of all, I would like to thank the Indian Orthopedic Association for the invitation, Dr. RAJAT AGRAWAL and Dr. Shamsul for the honorable invitation. I'm going to talk about the proximal femoral focal deficiency, or congenital femoral deficiency, or congenital short femur. It's all the same. Why to have a classification? Why to have a new classification? If we think about the current or the older classification of proximal femoral focal deficiency, they are almost unreliable. Small number of patients, hypothetical descriptions, many unclassified cases. Not only this, but we even have animation-based classification. From each center in Europe and the States, they have their classification, and they always have it on their names. But recently, we have animation-based classification. That means classification without cases. All the classifications are based on early diagnosis. So if you want to think of classification, they tell you if you bring the patients early, you can classify the deformity. If this is true, you can find this discussion in my paper about limb reconstruction in a resource-limited environment, if you want to read it. I looked at this case. This case presented at birth. So this is complete absence of the femur, right? Look with follow-up. A few months later, you have this picture, then that picture, and then that picture. So it's not complete absence of the femur. So early diagnosis doesn't mean at all in congenital short femur the right diagnosis. This is not true. This is a hypothetical idea. Again, look to this picture. Another congenital deformity or tibial hemimelia, look. This is the fibula. No tibia. At birth, but look with age. After a few months and after 4 years. So if you think about early diagnosis does not mean at all the right diagnosis. This is not true. And again, they put treatment protocols. The treatment protocols in the English literature are depending upon a very small number of patients operated by many surgeons over a large period of time. Very funny. Why? If you want to present a paper or a lecture or publish a paper about total knee arthroplasty, they always talk about the surgical loads. So they tell you it's very important to have a good surgical load. So if you do 500 per year or 1,000 per year, you have a good experience. But in our job, when they do one case every 2 years, they insist to publish it. And they present their great experience with one case every 2 or 3 years. A child with a congenital deformity in the Middle East. It's not only the Middle East, it's also in India and China. I've been to India and China many times before. The growth rate is more than 3% in Egypt. More than 1/3 of the population is under the age 15. And the incidence of congenital deformities is high. It's not the same like Europe. Tibial hemimelia is not one per million live birth at all. It's far more in our area. Again, with the present classifications, the hypothetical classifications, it doesn't help. Look to this patient. Congenital short left femur. And this is fibular hemimelia or tibial hemimelia. No one knows. And this is fibular hemimelia. Does it help if you plan for treatment? It doesn't help. So again, with the development, we ended up with animation-based classification. What's animation-based classification? It's animation, it's classification without cases. I've never heard that in my life. But unfortunately, this is very popular in proximal femoral focal deficiency. So this is the new trend, which should drive me to make this new classification. It's moving from animation-based classification to the real world. It's again moving from Mickey Mouse world to the real world. The new classification is based on 927 cases. My journey with proximal focal deficiency started with the first publication. First publication, Pediatric Orthopedics Part B, was 1993. It's about 30 years ago. 51 cases, and it's published with Franz Grill from Czechia, Franz Grill from Vienna, Austria, Pavel Dongel from Czechia, from Prague. Both of them were the ex-president of the European Pediatric Orthopedic Society. Gerhard Steinwender from Graz in Vienna, and myself. And we started perhaps many of the principles that I'm going to talk to about the new classification. What are the limitations of any classification? The limitation is you have many retrospective cases. You see the patient at the age 32. So you don't have the complete file of the patient since birth. Cases not operated before, 42% of cases. But most of them, more than 50% have been treated before. And you know the treatment changes the natural history of the patient. The third important point in the classification are associated conditions. And when I started the classification, I found that if you have a skeptical mind, but most of the facts, or the so-called facts, or evidence-based facts, are just illusion. It's called the illusion of evidence-based medicine. It's just hypothetical. It's about dreams and fantasies, not real cases. And this is an example. Associated conditions in a case operated before. Look to this case. It seems a very severe congenital deformity. But for me, look to the femur, it's type 1. It's type 4. It's a normal femur. It's almost normal femur, but short femur. So sometimes the so-called mild or severe congenital deformity, but you have very severe associated conditions. Again, look to the cases treated before. This case treated before, you don't have an acetabulum. And people talk about how to reconstruct the acetabulum. Again, this is fantasy. There is no acetabulum to reconstruct. Again, associated conditions. The same patient with congenital short femur and with this deformity, severe flexion deformity. Cases treated before. This case had been treated by the so-called super hip and ended up with this picture. Stiff hip, 70 degrees flexion, 70 degrees flexion knee. And look to the picture. Again, this is the real problem. If you want to make a classification, how to think about the cases treated before. Like this. She had this operation and so. How would you classify it? Again, even in such cases, look to this patient, had been treated 10 times before. This is another patient. And they ended up, the patient cannot have a prosthesis because you have severe flexion knee and knee stiffness. And this is another problem. My classification, you have 4 types of classifications, 4 types. Type 1, morphological abnormalities of the whole femur. That means you have the whole femur, but it has a different shape, and I will show you the example. Type 2, congenital absence. 2A, you have total absence. You don't have a femur, nothing at all. B, you have partial absence of the proximal femur. Type 3, abnormal proximal femur. 3A, apparent nexodarthrosis. It's not pseudarthrosis, it's apparent nexodarthrosis. Type B, coxavara. 4, short femur, just short femur. It looks like a normal femur, normal proximal femur, normal distal tibia, but just short femur. So you have 4 types. Type 1, morphological abnormality of the femur. And type 4, the whole femur is there, but it is shorter than normal. Type 2, congenital absence. Type 3, abnormal proximal femur. People talk about hip dysplasia, and they always included a knee instability in the classification. This is not true. There was no statistical relationship between the presence of hip dysplasia or knee instability. So you can have type 4, just short femur, and you have severe knee instability. And you can have a severe type with normal knee. So there is no guarantee. Knee instability can be in any case in this classification. Again, hip dysplasia. Hip dysplasia in such cases, sometimes it's very difficult to predict. Why? If you look to the acetabulum, it's almost, you have acetabular index, normal acetabular index. But it is global dysplasia. Global dysplasia, it means the whole acetabulum is small. It looks like you have a small head. So if you cover your forehead, your back is bare. So this is a complicated type of hip dysplasia. Associated conditions, perhaps in 38% of cases, like fibular hemimelia. And again, no relationship between hip dysplasia, knee instability, or associated conditions and different types of proximal femoral deficiency. And this is against almost all the present classifications. Why against? Because all the classifications are based in very small number of patients. Again, the most famous one is a hypothetical, is animation-based classification. It's not based on cases, not a single case. And this is again type 4. To start from type 4, this is just femur, short femur with this severe deformity. What about bilateral cases? Look to this patient. If you have a bilateral case, look to this complete absence. And this is coxavara. So in bilateral cases, you can have 2 different grades or types of proximal femoral deficiency. Type 1. We start from type 1. Morphological abnormalities of the femur. This femur is almost normal femur, but in a transverse position. That means if you look to this picture, it seems like this is a picture for measuring the anteversion. This is not true. This is plain X-ray, anteroposterior X-ray of this patient. This patient has congenital short femur type 1. He has the whole femur, but in a transverse position. The femur is 90 degrees in the sagittal plane. And this is the picture of the patient. I've been following this patient for 15 years. You don't have to treat this type of patients because I've corrected the deformity, the flexion deformity, and within a few months, return it back. So we don't have to treat it. And she's functioning quite well. Again, morphological type 1, you have the whole femur, but it's different in shape. from the normal femur. Look to the picture. Type 2, congenital abscess. 2A, total abscess. 2B, partial absence of the proximal femur. And this is total absence of the whole femur. Total absence, look, of the whole femur. With the follow-up, you see this picture of the tibia. This is not the femur. And at age 25, the medial part of the upper tibia took the shape of the head of the femur. Look to this picture. The patient is functioning well. So this is, we don't have a femur, but the proximal tibia took the shape of the head of the femur. This is the medial part of the tibial plateau, took this. So this is type 2A. 2A, complete absence of the femur. 2B, partial absence of the proximal femur. So this is type 2B, partial absence. 2A, complete absence in the same patient. So this patient in a bilateral cases, type 2B, partial absence of the proximal femur. 2A, complete absence of the whole femur. Type 3, abnormal proximal femur. A, abnormal neck pseudoarthrosis. This is apparent neck pseudoarthrosis. It's not true pseudoarthrosis. Again, this picture. Or you have coxavara like this patient. So type 3, abnormal proximal femur, whether you have apparent neck pseudoarthrosis or coxavara. Type 4, just short femur, just short femur. Again, and now I'll give you an example. This patient presented to me with bilateral proximal femoral deficiency. This type 3A, apparent neck pseudoarthrosis. You see this picture. She was not treated before on the right side. Left side was on the right side. Type B of coxavara. She was treated before, just valgus osteotomy of the left side, and they left this side and they told her there is no treatment for this type. You don't have any treatment for such a type with this angulation. So this is 3D, show you the deformity. We did the first stage, distraction, histogenesis from the apparent pseudoarthrosis. We put the frame proximal and distal and use this acetabulum also because we have short spaces. Then we start distraction from here for the so-called apparent pseudoarthrosis and correction of the deformity, and you see the bone formation. So this is bloodless correction of the deformity. We don't do any incision. Again, distraction, more distraction, and the correction of the deformities, severe angulation. You see the bone formation, bone starts to appear with the force, with the low of tension stress. And 2017, look to the picture. The second step. The second step started from 3 sites. The upper site, we did osteotomy to correct the deformity and to do something like pelvic support. Then we do chondrodiastasis because it's very short. You need about 20 centimeter lengthening, which is not possible except with chondrodiastasis from the physis of the distal femur. And then we fixed the tibia to correct the flexion deformity. So distraction, histogenesis, open and correction of the deformity, chondrodiastasis and correction of the deformity. And gradually, we did from the three sides, correction and lengthening, as you see, and correction of the deformity all together. And you see this picture and that picture, 20 centimeter lengthening about. And this is the picture, picture. Again, another case of apparent neck pseudoarthrosis. And this is the follow-up of the patients at birth. It looks like type 1. It's not type 1. It's not complete absence, type 2A. No, look, we have a distal part. It's not only the distal part. We have the head at the age of 3 years. So we start the first step by doing arthrodiastasis, just arthrodiastasis, which we published in 1993. The importance of arthrodiastasis. The arthrodiastasis stimulates the so-called apparent pseudoarthrosis to develop. It's between the acetabulum and the femur, no incisions. And you see the picture afterwards. Don't have to put a plate or something. Then we did corticotomy and lengthening at the same time. You see the lengthening area before and afterwards. You see with the follow-up at birth and after lengthening. Another case of apparent neck pseudoarthrosis. Look to the follow-up of the patient. Again, arthrodiastasis is very important. We published that 1993. And after that, and this was the picture of the development of bone, we put valgus plate, as you see here. And we can do lengthening afterwards. Again, with apparent neck pseudoarthrosis, simple solutions, very simple solutions. Arthrodiastasis, then valgus plate, the lengthening of the femur and the tibia. If you have just a short femur like this or that picture, you can do lengthening of the femur and tibia at the same time. Failure of previous operations, you can do, again, valgus osteotomy of the upper femur. This is failure of plate, and again, lengthening. Failure of previous operations, you can do pelvic support osteotomy in such a case. You see, we don't have an acetabulum, and there was a trial to treat it before. Look at that. We did pelvic support osteotomy. And this picture. Super hip, the so-called super hip, and ended up with fixed flexion 70 degrees of the hip, fixed flexion 90 degrees of the knee. And you see, this is the picture of the patient. And we fixed the acetabulum, and we corrected the acetabulum between the fixed flexion between the acetabulum and the upper femur. And we did corticotomy. Again, we corrected gradually the flexion knee all together. You see in this picture, you see the lengthening area and the correction up there. And as this is the picture. Before and afterwards. Finally, we have 4 types. This is my new classification. Type 1, morphological abnormalities of the whole femur. You have the whole femur, but it's different in shape. Type 2, absence of the femur. A, total absence. You don't have a femur. And the upper tibia will take the shape of the femur. The medial condyle, the medial part of the plateau, will take the shape of the hen and neck. 2B, you have partial absence of the proximal femur. 3, you have abnormal proximal femur, apparent neck pseudoarthrosis or coxavara. Type 4, just short femur. Again, you can have knee dysplasia or knee instability, hip dysplasia, knee instability in any case. And you have to manage according to the situation. You have to manage according to the problem. It's not part of the classification, but each case, you have to expect the presence of hip dysplasia, even if you have just a short femur. And you can expect knee instability, severe knee instability, even if you have just a short femur. There is no guarantee and there is no relationship, any relationship between the type in this classification and the presence of instability. And you have to manage accordingly. The treatment, we don't invent the treatment. The treatment depends upon the Elizarov principles. Again, we are against everything. We put the names and we say, we discovered something new. This is not true. All the treatment are based on Elizarov principles. And we started this 1993. Thank you so much. Thank you for inviting me.
Thank you, sir. Thank you, Professor HOSNY, and for this fascinating talk and such a wonderful case results. Most of us will not even touch these type of cases, even than to operate. Sir, I have one question for you.
Yes, sure.
Yeah, actually, because what we have seen in our practice that these type of cases comes once in a while, and especially from the rural areas, and they don't have much money. You can't refer them to any other place. So is there any, and suppose a surgeon knows Elizarov, but is not a master in doing this femoral deficiencies, but the patient says something, at least something, can you do something at least? And the patient can't go to a very higher center. So is there any minimal something the surgeon can do just to make the patient a little better, not to treat the whole deformity?
The problem is when we think about such cases, we think from the American or the European point of view. They give us the impression that these cases are very difficult to treat. And if you want to treat them, you have to take them to a sophisticated place, and it has to be very expensive. Why they have created this imagination story? Because they have very few number of patients, and we have very few number of patients. They created this imaginary idea. This is not true. We treat these patients in a very simple way. That means here in Egypt, when the people coming from, we teach the doctors when they come and they help us, my facility or the operating theater on my clinic, and I advise them not to refer the patients to me. They treat their patients in their hospitals. Think about these operations. Are they costly operations? Of course not. If you think about the operative procedure, it's either you do an osteotomy or a valgus osteotomy or corticotomy, or you do nothing at all. You do chondrodiastasis. It's a closed treatment. So actually, the first part of the question, you don't need an expensive place or something like this. And all the patients are daycare patients. They stay in the hospital either one day or they go out the same day after the operation. Nothing sophisticated. We don't have super operations. You know, I'm a simple-minded surgeon. I do simple operations only. So these cases are treated in a simple way. Everyone can treat them with a little experience. And this is my stand or my point of view.
Can I ask?
Yes,
Hello?
yes, sir.
GAMAL HOSNY, first of all, I must congratulate you for this showing these fantastic and very complicated cases. And we are also facing these kinds of congenital You can see CFD or PFFD. Beautifully, you've explained, you have shown. But if you see the literature, Aitken classification or Papa's classification, there are lots of Androde Palace classification and Kurgan's classification. The cases transverse one that you have shown, your type 4, fantastic. Don't need to touch any people with this transverse type of congenital, that is deformity. And my one observation is your lecture, why you are telling that this one is the apparent pseudarthrosis. You can see, obviously, if you go for MRI or in the X-ray, you can find it. This is of course, the pseudarthrosis. And this is written in the literature. And the way that you have treated, I am 100% agree with you. And in my country, we are also facing lots of problems with this kind of PFFD. And the problem is that only what I see, the rotation plasty, sometimes you need to go that one. What about your comment regarding the rotation plasty of the patient when they comes with the absence of the total femur?
We don't have any experience with rotation plasty. Our patients, they don't accept this type of treatment. And we don't offer them this type of treatment. We don't think it's valid. Perhaps it's valid in Canada or the States or something. But we are different. And I've told them, you attend the meetings.
Yes.
We are not, you have to accept the differences. If you want me to learn from you, you have to learn from me. Because they try to convince us that they have the truth. And I'm sorry, in the limb reconstruction, and I've written that in that paper, most of the cases of limb reconstruction are coming from the low-income countries, coming from Egypt, from Bangladesh, from India, from Iraq, from Jordan. Most of the publications are coming from the high-income countries. This is comical.
Correct.
Why on earth you want to teach us? You have a very small number of patients, but you insist to show us your experience, and you want to teach me, and this is the real problem. This is the real problem of the limb reconstruction. And who has the louder voice? People in the States or Europe, right? But they have very small number of patients.
Yes.
Why? This equation has to be corrected because it's not the right equation. The people who are treating these patients on a daily basis, like you, we know that quite well, they have to present their ideas more.
Thank you. Thank you.
Good evening.
Excellent.
Hello. Good evening, Dr. HOSNY.
Dr. Agrawal,
how are you? Yeah.
Fine, and you?
Fine. So I've seen all the presentation. There is one case in which there was a total absence of the femur.
Yes.
So the femur has taken the shape of the tibia. So have you done ever lengthening or something in that case?
No, because the patient refused any interference, which was good for him. And he's behaving quite normally because, the upper tibia, it looks exactly like a hip. You have a head of the femur and you have, so for him, it was no, he doesn't need any interference. He refused to have any trial, which for me now, after, the patient, I think he's now 32 years or something, it was wise not to do anything for him because the expected shortening is something like 40 something. And at the same time, he's functioning well.
Okay, can I talk?
Yes, Dr. Ruta.
Thank you very much, Professor HOSNY, for giving a very useful and practical classification of PFFD. I just wanted to ask you about the apparent pseudoarthrosis. So in the apparent pseudoarthrosis, usually is there a cartilage enlarged present in the pseudoarthrosis? And do you check it with MRI?
Not at all. Because I know that this is not a pseudoarthrosis. For me, it's a fact.
There is cartilage in between?
Yes, when you do arthrodiastasis, as I've shown you, and this started, actually, it was not my idea. It was I think, Pavel Dongol and Franz Grill. They were doing arthrodiastasis, and they noticed during the arthrodiastasis between the acetabulum and the distal femur that bone develops in the so-called or the apparent gap or something. And since that time, I always do arthrodiastasis in the start from the young age, at age 3 or 4, for 4 months. And usually we have during this phase or immediately after the development of bone. Besides, if you leave it and if you leave everything as it is, within few years, you are going to have bone. We all know this.
Yeah,
but you are going to have severe coxavara, something like 160 degrees or something, which is very difficult to treat. And if you want to treat, you have to do massive surgical dissection, and you have to dissect a lot of bone to correct the axis. Yes. But if you do arthrodiastasis from the start, you're going to have bone earlier, we think so. And the angle would be something like 90 or 80 degrees, which is easy to correct. If you want to put a plate, if you want to do bifocal, external fixator up and down, we do both. Sometimes we put a plate, and in such a case, you don't have to resect the bone. It's just to do an osteotomy and correct from that. So you save the soft tissue and everything for lengthening later on.
Yes, I think it's a magnificent idea to do that arthrodiastasis. It's a great idea.
Oh, thank you.
And what is the youngest patient that you do it? What is the earliest age?
It's a difficult question for me because, I have usually the patient come to me late, at a later stage. But if they come to me earlier, it depends upon the type we are going to treat. If I have the apparent nexodarthrosis, we start from the age 3. I don't wait for an older age.
Okay. Thank you, sir.
Welcome.
Thank you, ma'am. Shamsul, has anybody having any other questions?
No questions from YouTube. Do you have any questions from the panel?
And meanwhile, sir, I would like to take this opportunity to request you from...
Sorry, can I ask Dr. Jamal one question?
Yeah. Dr. Please go ahead.
Dr. Jamal, because, yes. By your classification, you told us that we have things are changing with time. Once you diagnose a patient with total absence in a while, maybe it will be partial absence. So do you suggest an age profile for us in order to take the classification and then do the treatment for the patient?
This is wise, of course. We don't have to make an MRI for all the patients. This is funny. Why? To give the patient general anesthesia at the age. I've seen that in the English literature. They give the patients at the age 2 years or something general anesthesia to see the cartilage. Why on earth? I don't have to. Because I know with the time I will see everything. I don't have to expose my patients to the general anesthesia at this young age and the MRI or something. But if you wait longer, as you have said, because in an early phase, I'm not going to operate on the patient at the age of a few months in congenital short fever or proximal femoral focal deficiency. So I'm not planning to do anything in the first 2 or 3 years. So why not wait till you verify your classifications? There is no magic. Every lesion has its own merit. You don't have to apply the principles in my head to each thing on earth. Behave with proximal femoral deficiency is a different lesion. It's a group of conditions. It's not one condition. It seems like you apply the principles of the femur to the humerus. You think that the hip joint is similar to the shoulder joint, which happens to me 30-something years ago when I was reading the literature of humeral lengthening. And the people were thinking about the humerus exactly like they're thinking about the femur. And they're talking about the stability of the shoulder exactly like they talking about the stability of the hip. We are talking 2 different entities. But it's our mind. We try to simplify things to make an approximation. So waiting is is quite accepted in such a situation.
Thank you very much.
One question from my side.
Yeah, ready, sir, please.
Hello.
Hi, Professor.
Hello, sir. Yeah, it's a it's a complex deformity consisting of joint dysplasias, pseudoarthrosis, and deformity, and the LLD, which has to be given the maximum priority in order to get a maximum benefit to the patient.
It's always easy to say you have to manage the hip dysplasia first. It's easy to say that. And I've seen that in the literature. But this is not the problem. The problem is that sometimes you cannot evaluate the hip dysplasia. How would you evaluate hip dysplasia? It's shallow acetabulum, right? So you measure the acetabular index and you have a shallow acetabulum. But in many cases, it's not a shallow acetabulum. It's a small acetabulum. And in such cases, it's very difficult to operate on a small acetabulum. So if you don't have something which is quite clear that you have to correct first, but whatever osteotomy you do, whatever you do, Salter, Pemberton, or whatever type of hip osteotomy, tennis, or bone graft or Chiari osteotomy, sometimes you don't have. If you have this picture and you correct it, it's okay before limb lengthening. But sometimes, which happens to me, yes, during lengthening, you have subluxation of the hip. I didn't present such a case, but later on I will. Or after lengthening, after removal of the fixator, you have dislocation. So there was some sort of complex acetabular dysplasia that you didn't appreciate it at the beginning, and you have to manage later on. So people take care. Hip dysplasia in such cases is a difficult problem, difficult to evaluate, because in many cases it's a global dysplasia.
Thank you, sir. And Shamsul, any other question?
So do you have any more questions from panel, or shall we move ahead?
Yeah, and meanwhile, Professor Hosny, I thank you once again on behalf of Asam India to accepting our invitation and giving a wonderful lecture on congenital deformities. And on behalf of all of us, yes, sir. So I also request you that every year, Asami India try to send 2 fellows to different countries, different stalwarts, to have a maximum exposure. And we will request you to find out a way in which we can send 2 of our fellows to your center or in Egypt, other places, for an observationship of 2 weeks, or let's say a fellowship of 1 month. And we will request you to find a way. We will communicate later on. So we can have maximum collaboration between Egypt and India, and vice versa. We will invite the young doctors from there to have an experience of the work which is going on in India in different places.
It's my pleasure and honor for me, definitely.
Thank you,
it's all
sir.
a pleasure to have my Indian friends in all this.
Thank you, sir. Thanks a lot. Shamsul, please go ahead with the next presentation.
Right, sir. So next we have our first question, RUTA ma'am. Dr. RUTA KULKARNI is past president of Asami India. She is professor of orthopedics and head of department of pediatric orthopedics at Swasti Yog Pratishthan, MIRAJ, Maharashtra. She has delivered lectures on elizero and pediatric orthopedics at various national and international platforms. She has chaired numerous sessions at various national and international conferences of repute. She has numerous publications in various national and international journals, and she has conducted many workshops in elizero and deformity correction. Her field of interest is deformity correction learning. With this, I request RUTA ma'am to share a presentation. Thanks, ma'am. RUTA, please.
Yeah, I'll start sharing my screen. Okay, so thank you, Dr. Shamsul and Dr. Rajat, for giving me this opportunity. I'm going to share these 2 cases. So my first case, you can say it's Professor HOSNY's type 4 of congenital short femur syndrome, PFFD. The girl was 15 years old and she came to me with 12 centimeters of shortening and she had distal femoral valgus. Fortunately, her knee and hip were stable. There was no obvious ligamentous laxity in the knee. So that was her X-ray. You can see the distal femur is in valgus. So this was her shoe race. She came with such very uncomfortable, ugly looking shoe race. So first I did her femoral lengthening and put a slotted plate. This is the technique developed by me, slotted plate and ring fixator. So before putting in the plate, I removed a wedge and corrected the distal femoral valgus and then put this plate, put screws in the distal fragment and left the proximal segment free of screws. I lengthened 7 centimeters in the femur. I also extended a ring below the knee because though there is no obvious ligamentous laxity in all cases of congenital short femur syndrome, as a precaution, I always go across the knee and fix it to prevent any subluxations or dislocations during lengthening. So you can see here I have lengthened for 7 centimeters and now she is still 5 centimeters short. So that's her actually after removal of fixator. I removed the fixator quite early, within almost 3 months. And then I went for tibial lengthening. I lengthened her tibia with the same technique of lengthening with plate-assisted lengthening, and I use a slotted plate here. So that's her femur and that's her tibia and that's her ORG. There is difference between the knee levels, but up to 5 centimeter difference in knee level is acceptable according to the literature. I have published this in the recent JLLR. And this I have published long back actually. And this is very important, famous article by Dr. Mark Dahl. He says that plate-assisted lengthening is a safe technique that minimizes time of external fixator and accelerates rehab and weight bearing. So that is true in cases of PFFD also. I could remove the fixators early and I could do good rehab. My second case is a case of tibial hemimelia. I use Jones classification in tibial hemimelia. So this case is type 1B. Actually, Jones type 1, in Jones type 1, there is complete absence of tibia. But there is subtle difference between A and B because the prognosis between type 1A and 1B is different. And the modality of treatment is also different. So in type B, actually, the proximal tibia eventually ossifies, like Professor HOSNY showed in his lecture. So that is type 1B, and there is presence of extensor mechanism functioning. Distal femoral epiphysis is also normal in type 1B, and all these things are absent in 1A. So this 2 months old baby was brought to me by her parents like this. So I could diagnose with clinical examination and on X-ray that this is type 1B and not type 1A because she could extend her knee. Her distal femoral epiphysis was normal. So that's her X-ray. So at the age of 1.5, I did this. I did a soft tissue release and I did a supramalleolar osteotomy of the fibula and brought her foot under the fibula. And I casted her for a while. And that's her X-ray at the age of 2 years. You can see the proximal fibular enlarge has ossified. At the age of 3, I did this surgery. I did tibialization of fibula. I cut the fibula and brought it below this tibial enlarge and passed a nail from foot to the fibula to the tibial enlarge like that. I kept the nail for a while. So you can see the fibula is now nicely developed as tibia. The foot is sitting nicely below the fibula, which has now become tibia, and it's plantigrade. And tibia is growing. So this is at the age of 6 years. You can see it's well aligned and stable. Both the knee and foot are stable. And she can not only walk, but even can dance with the orthosis. The only problem is she has 6 centimeters of shortening and she can wear even stylish shoes. So at the age of 10 years, I decided to lengthen her fibula, which has now become tibia. And I also did this fibular epiphysiodesis. So I did 7 centimeters of lengthening, and throughout the lengthening, she was very cooperative. At the end of lengthening, I did midfoot osteotomy to correct her foot deformity. And that's her. You can see her tibia is straight, foot is well aligned, knee is stable. And this is how she is walking. Thank you. So I'll stop sharing. Thank you for your attention.
Thank you, ma'am. Any questions from the panel, please?
Yeah, one question. RUTA madam, hello?
Yes, sir. Yes, sir. Yes, Dr. Reddy.
Yeah, what precautions do you take to prevent hip subluxation or dislocation in femur lengthening? And at the same time, how do you take measures to prevent knee stiffness in femur lengthening?
Okay, so in my case of femoral lengthening, actually the hip was stable. If I feel there is instability in the hip, I tackle it first before lengthening. So depending upon the type of instability, I handle the hip instability first at any cost. In this case, actually, there was absolutely no hip instability. There was a little coxa vara, but I didn't correct it because the hip was very stable. About the knee stiffness, to prevent knee stiffness, I use this technique of lengthening over slotted plate, where the fixator is there only during the distraction phase. And after that, I remove the fixator and start knee mobilization. So I keep the knee straight during the distraction phase that is necessary to prevent knee subluxation. But as soon as the lengthening phase is over, I start knee physio. And this girl has full knee flexion.
Awesome. Any more questions? Rajat sir, are there any questions?
Is there any question from the panel? Sir, I would like Professor HOSNY also to comment on the beautiful case presentations by Dr. Kulkarni. So will you like to comment anything, sir?
Yes. For the first case, I think you did one osteotomy for the femur for the first case.
Yes, only one osteotomy.
Yes, I think the patient has 2 deformities: varus of the on the middle, then valgus in the lower part. I think you did your osteotomy in the apparent apex or the core of the deformity, in between both of them. That's right?
Actually, the varus was in the hip. The varus was very proximal. I purposely did not correct the varus of the hip because the hip was stable in that varus. If I had corrected the varus into valgus, actually I was afraid of, subluxation of the hip during lengthening. So I didn't touch the hip varus proximal. The varus was very proximal. And the distal femur had valgus, which I corrected at the cora. I removed a wedge and corrected that valgus. And left the proximal varus intact, actually.
For the second case,
yes, sir.
This is an excellent case, and I think the knee is stable. Yeah. But the problem is, I think that you cannot have the whole discrepancy from the fibula or the tibia, the centralized fibula. Would you like to do short lengthening from the femur to compensate part of the for the limb length inequality? Because I think she's too young. She's going to have more shortening.
Yes, sir. She is going to need second lengthening actually at the age of say 15 or 16. And yes, you mean epiphysiodesis of opposite side? Are you saying that, sir?
No, I mean in the same limb. We do over lengthening of the femur in some cases like this.
Over lengthening of
if you have a stable knee.
Okay.
And again, you will not have that both knees at the same level, but functionally, there's no problem with that.
Functionally, there is no problem at all. Yeah, that's a good suggestion, actually. That's a good suggestion.
Thank you.
I've never done that.
Yeah, one question I want.
Yes, sir.
Yes. RUTA, in that case, where the tibia fibrillation was done, what is the position of the ankle joint? What I'm finding there, that ankle joint most probably is either fused there.
Ankle is stiff. Ankle is stiff, sir.
Yeah.
I cannot have a mobile ankle there. It is stiff.
That is the point.
Yeah.
So we cannot do.
But that's okay. I mean, that's a small price to pay. Her knee is very stable and fully functional. But the ankle is stiff. She's walking quite well.
Yeah. Yes, because you don't have an ankle from the start. You have a fibula. Exactly. And this is the real problem. When the people think about it, the patient, they have to know they don't have an ankle from the start. We simulated the ankle by pushing the fibula. So they will never have a normal ankle. So even if you have a stiff ankle with a plantigrade foot, this is excellent for me.
Yeah.
So can I ask, please, about the foot?
Yes, sir.
So in cases of, this is for all the panelists, please. Yeah. I wondered if there is a cases of TB hemimelia or fibular hemimelia that will end in a functional ankle, actually. I wondered if there is any. Do you agree?
Yes, you're right, actually. But there are very few types, especially fibular hemimelia, type 2 with, say, ball and socket ankle.
Yeah.
That ankle is a mobile ankle, and it's quite functional ankle. But apart from that, type 3 of Pele's and all those types which are very severe hardly have any functional ankle. All of them end up in stiff.
Can we do for them an infusion, chondral fusion, just remove the cartilage part of the talus and the distal fibula or tibia from the beginning and telescoping the talus into the fibula or the tibia from the early? Can we offer this, or that will affect their growth later? We will postpone this to the later age.
I can never offer a fusion at early age. I wait till the child becomes at least adolescent, So doing fusion at such early age, I don't think it's a good idea.
So we can preserve the physis. Is it a good idea? We can physis sparing fusion for while you're using a frame, just only the cartilage and the frame catching the talus. Can we offer this for them?
See, you know what? After treating them, they usually land up already in stiff ankle. So you don't have to do extra efforts to make it stiff or fuse. They usually land up with stiff ankle. So in case they have a painful ankle, you have to go in and remove the cartilage and do the fusion.
Thank you very much.
So another question.
My experience is a little different about the mobility in the ankle joint, which I'll be showing soon. So I'll let Professor Agrawal go ahead with this question. Please. Go ahead, sir.
Yeah, one thing I want to ask you that when you do the plate assisted, after finishing the lengthening, you do screw fixation percutaneous.
In plate assisted lengthening, I didn't. So the remaining screws I put percutaneous under C-arm. Yeah.
That's good. Good idea.
Thank you, sir.
Thank you, ma'am. Professor Chaudhary wanted to add a comment.
Please unmute, sir. Please unmute, sir.
You're on mute, sir.
Yeah, so thank you. The next presentation, we can salvage quite a few ankles. So, and some are really beyond salvage. Like RUTA ma'am said, I think typically the worst ones I have found are the ones that end up also having a rocker bottom kind of foot over and above those are the really difficult ones. But we managed to salvage quite a few. And when I start my presentation, I hope to show the ankle recon as well.
So just a moment, sir. Thank you, sir. So next we have our eminent Professor Dr. MILIND Chaudhary, sir, as faculty. Is Director of International Deformity and Lengthening Institute at Akola, India since 1989, and pioneering Elizero surgeon in India since 1989. He is Editor-in-Chief of Journal of Limb Lengthening and Reconstruction for Walters Clover. He has trained more than 19 orthopedic surgeons from all over India and abroad in post-PG clinical fellowships. He is president of Asami India subspecialty of Indian Orthopedic Associations since 2009-2013. He is an honorary consultant at Jastrok Hospital, Mumbai since 2006. He is honorary assistant professor of orthopedic surgery at GIPC, Akola from 2002 to 2006. He has organized International Asami Conference as a president in September 2014. He has performed more than 4,000 Elizero surgeries from all indications. He has lectured in international, national, regional, state conferences, more than 120 lectures in 26 years, including CME 3 icons. He has published 6 chapters in textbooks, Zurich Orthopedics, IO textbook for angle deformity correction, non-unions, infected non-union. And he has treated patients from all corners of India and 4 continents. So thank you, sir. MILIND sir, please share your talk, sir. Thank you, sir.
Thank you very much. Our dynamic Dr. Shamsul, for your very kind introduction there. Thank you, Dr. Rajat Agrawal, the President of Asami India. It's an honor to follow Professor GAMAL HOSNY and Professor Mrs. RUTA KULKARNI. So I will be speaking briefly about fibular hemimelia, in which we will talk not just about lengthening, but also about ankle and knee reconstruction. Can you see my full screen?
No, sir. Please go full screen, sir.
Can you see my screen?
Sir, please go full screen.
Full screen on the Mac now. Okay, just give me a moment. Give me a moment. Yeah.
Yeah.
Can you see it now? Full screen?
No. Please click once again, sir. Please click once again.
Yeah. Is that fine?
Okay. Right.
That's good now?
Yes.
Okay. Right. So the problem list in fibular hemimelia is not just the limb shortening that happens chiefly in the lower part of the limb in the tibia, but also in the femur sometimes. The big problem is really the fibular deficiency at the level of the ankle with a talocalcaneal malposition or a malfusion, which is a synostosis of the talus and the calcaneus, with the calcaneus lying almost parallel to the talus. There's also the one that's most visible, of course, is the procurvatum and valgus deformity in the tibia, but frequently that's not the one that creates the most problems, even though it's the most visible. Just like the deformities in polio and CP, the children come to us with foot and ankle equinus and deformities, and the eye is drawn to that, whereas that's not the most important deformity. So the procurvatum and valgus in the tibia with the dimple, though it's the sort of pathognomonic condition, it's not really the most important. Then there are absent rays of the, which are, I'll come to that. And of course, the more important one is the one that manifests at the age of 11 and 12 years, when the children become a little heavier and stronger. The ACL deficiency, which is an integral part of most fibular hemimelia, starts acting up and creating instabilities. So the minor problems are, of course, the absence of the toes, which also may be pathognomonic. You may also have a club foot-like deformity, and the valgus and external rotation deformity of the femur. Sometimes you can also have a little acetabular dysplasia, but that's not so common. So let me start by sharing a few examples. Dr. Ruta ma'am referred to the ball and socket ankle. Here is such a case. This is a young lad who has almost 6.5 centimeters of shortening. This is a fibular hemimelia, the forme fruste of that. If you notice carefully the zoomed in part of the ankle, typically the fibular physis is at the level of the ankle joint. Whereas in this case, the fibular physis is riding high. It's at the level of the tibial physis, and this is like a ball and socket ankle. So this is fairly good, but there's a lot of shortening, and you can see some valgus. So you can, this is an easy one to correct. You can perform just tibia lengthening, taking due care that the fibula is not going to ride above, and you maintain, you try and give him equal lengths. You can, we did more than 6 centimeters in one stage, and his ankle is preserved, and so is his function. So this is a happy instance of a very relatively simple case. Now, when we have moderate presentations, as in this young child, you have like a clubfoot-like picture with absent raise of the foot, a shortening, external rotation, and valgus deformity in the femur. So this is the scanogram that shows, and these are the X-rays that show his talocalcaneal coalition. So in children like these, we can perform a composite correction. With tibia lengthening, we can correct the forefoot varus, pronation deformity, the cavus, and we can correct the hindfoot deformity by distracting at the level of the hindfoot. What looks like a complex frame is really just helping us to achieve correction at all 3 levels. And of course, as you all know and are experienced in this, all these children are very comfortable with the Elizarov fixator. They really have no problem whatsoever. So here he is at the end of the treatment. He's had 5 centimeters of lengthening. His foot is reasonably well corrected. And so is the, we've brought the calcaneum down at the level, and he's got a fairly decent ankle function, and he manages to, let me see if I can run this video, walk very nicely. He's got, absolutely no difficulties in his function in the ankle. When we have children who present to us with this classic procurvatum, I'm sorry about the X-ray, the procurvatum and the valgus, and they have these severe ankle deformities. You can see how this talus and the calcaneus are almost collinear to each other. A child like this presenting at a tender age with the typical dimple, though this is the deformity that catches the eye, the severe deformity is chiefly at the level of the ankle. So when he was very young, we did the first surgery in which we realigned the hindfoot by opening a wedge on the lateral and the posterior aspects. We resected part of the fibular analog, and we inserted the analog in this opening wedge osteotomy in the first stage. In the second stage, we performed the lengthening with the Elizarov, and we've held the hindfoot in position, and this is how he looks like. The hindfoot is reasonably well aligned. But what happens to the hindfoot as the child grows older? Of course, we've performed lengthening on 2 occasions. We've performed lengthening in the tibia, you can see, and in the femur as well. And later on, he went on to develop again a significant amount of valgus, because you can see the fibula, which is very thin, has migrated dramatically proximally and is offering no support at the level of the ankle. Note that after any lengthening in the congenital cases, we have to protect the regenerate with the help of rush nails or any other flexible intramedullary rods, because otherwise they're bound to develop refractures. This is especially very true in congenital shortening of the femur, and can be very painful, for the patient's parents to see that there's this fracture that's occurred after this long and difficult treatment. So whenever we schedule the patients for removal of the fixator, we have to insert these rods. So having done that, now the patient presents to us at an older age with this significant deformity. He's now about 9.5 and he's obese. And sorry, I'm on the webinar. Can I talk later? Thanks. So what we have to do is hindfoot realignment, by subtalar joint realignment. So here he is. This is a lateral incision taken. Sorry about the fuzzy picture, but you can see how we've created an osteotomy and opened up with an arthrodesis spreader and inserted some graft over there to keep it in place. Initially, he had wire, and then you can see there is also we have performed a resection of the tibia, a shortening resection of the tibia to get rid of the significant valgus that was present, at the level of the lower tibia and the hindfoot. So this has aligned his ankle reasonably well. And later on, he came to us for his ACL reconstruction, which I will show in this child. So here is a child who doesn't have this procurvatum and valgus. So he comes with a lot of shortening, for which it is easy for us to perform the lengthening, 5 centimeters. It's not very difficult. Now what happens is that the hindfoot valgus that you see over here is with the proximal migration of the fibula and a little bit of the ball and socket type ankle. What we have done is the hindfoot realignment with a different approach, which has not been reported in the literature. We do a fibular transport. Now, Dr. Paley has taken a different approach. He shortens the tibia. He calls it the SHORDT, the shortening realignment of the distal tibia. In some instances, we can get away by performing a fibular transport, which is what I have done. In this child, as you can see, the fibula has been transported down. You can see the fixator over here. There's a half pin. There are 2 half pins in the distal fibula, along with the second episode of lengthening. The fibula has been brought down to station, you can see, and there are 2 screws which are holding the 4 cortices to get the fibula in the right place at the station. And this is how his fibula has been maintained in place, and he does well. Then he goes on to develop a little bit of valgus in the lower femur and upper tibia, for which he gets a guided growth. You can see the beginnings of anterior cruciate ligament deficiency here as he's growing older. Though he's struggling with weight gain, he's doing a good job. And when they put on weight and when they become this age, when they're very active, athletic, because of peer pressure or family pressure, that's when they start experiencing difficulties in the knee. So which is where we have to go down and perform an ACL reconstruction using the Macintosh over the top, using the fascia lata. This is the fascia lata harvest, and we've split it into 2 bundles. And we have not only done an over the top, you can see it's been pulled out. This is going over the top. It's pulled out through the tibia and then fixed with a biotenodesis screw. And also on the medial side, we have done the reverse Macintosh procedure. And here he is with reasonably stable knee joint, and the wobble has reduced quite a bit. And so ACL reconstruction, more and more we are doing in these children, which is rather difficult for various reasons. One is there is an absence of knots. Secondly, the amount of tendon harvest that you can get is not enough to give you a very thick, diameter of the tendon, and you may have to quadruple it or take an associated tendon. You have to watch out for these children. Some of them are hyperactive, and when you stabilize them, you have to make sure that they don't fall or they're not aggressive with the physiotherapy, which can lead to failure. I've had a couple of failures of ACL reconstruction in fibular hemimelia, and also my share of successes, especially if they fall down or if they're aggressive with physiotherapy, the reconstruction can fail, and it's very heartbreaking. It's very difficult to undo and reconstruct again. Here are some simpler cases. This is a young child who comes to not a very obvious deformity, a lot of shortening. So it's simple to do a lengthening, say 6 centimeters when he's a little child like this. Then he comes with valgus. Slowly the valgus remodels on its own. Then he becomes an adolescent like this, presents to us with this deformity. And you can see the amount of shortening. He's ready for a lengthening. So at this stage, he gets a lengthening over a nail. This is, I think, the lengthening over a nail, which I've been doing since 1994, 29 years now, several hundred of them. So you can use any nail. This is a straight nail which has been modified. You can see he developed actually a premature consolidation. I did a repeat corticotomy without opening the nail to allow him to get a full length. And here he is with equal leg lengths. His hind foot function is reasonably good. Limb lengths are almost equal. And he went on to become a medical student at KM Hospital, is graduated now and has become a physician. And I will finally end with this case. This is the severest example of fibular hemimelia, where the procurvatum and the valgus that you see in the tibia has gone to such a dramatic extent that the deformity is almost taking the foot behind. It's more than 140 degrees of procurvatum and valgus. So what can we do in such a case? So the foot is facing almost upwards at the ceiling. Here we had to resort to the TSF fixator, in which we gradually straightened him out and brought him out until this leg, you can see the procurvatum is completely corrected. The calcaneum is in dramatic amount of equinus, but now the foot is facing downwards. and you can have a limb that's now finally facing forwards. So this is, I suppose, the entire spectrum of fibular hemimelia. And I thank you very much again, Asami India, for giving me this opportunity. And I'd be happy to share, answer any questions if there may be. Thank you.
Thank you, sir. As always, an excellent full book series of presentation, like every case of every problem from head to toe. Sir, where do you find all such type of cases?
So, as Professor GAMAL HOSNY says, you know, we are in India. There's no shortage. It's an ocean. And I've been working on this for 34 years. So thank you very much. It's really it's a learning experience. Fibular hemimelia is a great learning experience. There's so many new surgeries you have to learn. It's not just the lengthening. The hind foot and the knee reconstructions are rather difficult. And it's an interesting learning experience to deal with these children and young adults.
Okay, sir. Thank you very much for this presentation. Nice presentation. I want to ask, in the last case, in which there was a deformity of the foot so much. So ultimately, what you have done that? The last case of the fibula hemimelia.
This is the one. This young man, we have done this in the year 2003, because I started the TSF fixator in 2002, and he has not presented to us since then. He's had a very good correction of one of his limbs. He's probably not come back, not come back for the other. But now at least the foot is facing forwards. So that's the benefit that he's received, instead of having to walk on the lower part of the deformed segment. I'm trying very hard to trace him so that I can offer him a similar treatment on the opposite side and do whatever residual hind foot correction he needs. Because as I've shown before, the hind foot deformity increases with age, and we frequently have to perform hind foot correction once or twice at least. Once may not be enough.
Thank you very much. And what we have found out in all the fibula hemimelia, if the fibula is there, the main problem is the valgus deformity. So what we do, we bring the fibula downward so that it touches the talus. When the fibula comes downward, so it does not allow the valgus deformity. That we found there.
Yes, that's one of the cases we have done. I've also tried the SHORDT, shortening realignment of the distal tibia shown by drawer, wherein especially when the fibula is in very good shape, so we can actually shorten the tibia and release the tibiofibular interosseous ligament. What that does is it makes it very easy, because the bone shortening is always going to help us to keep the joint very stable. So unfortunately, I didn't have enough time. I'm sorry, I was out of station to show the SHORDT cases that are actually the one child I've shown in the ankle. That is an SHORDT, but the fibula is not present. So there is a resection of the tibia. The valgus is corrected by a wedge resection, in which we are resecting more on the medial side, more on the anterior side to correct the procurvatum and the valgus. And in the presence or absence of fibula, this shortening of the tibia at the level of the ankle dramatically helps in allowing the hind foot to function. This was the question posed to Professor Dr. Mrs. RUTA Kulkarni. And this is the SHORDT, or the shortening of the distal tibia, is one way by which you can prevent the excessive pressure buildup in the ankle, which leads to ankle stiffness. So that's one thing to, I would say, do more and more when the opportunity presents, especially at the lower tibia. Shortening instead of creating an opening wedge, shortening will help in reducing the tension, releasing of the interosseous ligaments, releasing of the unlag. This will help in sort of preserving the cartilage and mobility in the ankle.
I have a question, please.
Yes, sure.
Yeah.
Yes, Professor.
Two things. One, if we do the lengthening or making the fibula coming down as your technique, as you described in your technique, did you find some instability concerning the syndesmosis after letting the fibula comes down, or it will be, because I think if we go make the fibula down, maybe we'll stretch at the same time, we will stretch the syndesmotic ligaments together. Do we need to have something for the soft tissue with the bony procedure or not? The other thing with the shortening tibia, Bailey described that after releasing the syndesmosis and doing the shortening, you have to put the endo-button to join to make the syndesmosis again. Is that going to make the fibula stable? Sorry, the ankle joints more stable, or there is a failures of soft tissue reconstruction afterward? Thank you very much.
Yeah, thank you. It's a very interesting question. And I'll go back to the case and talk about it a little bit. So bringing the fibula down cannot be done in every case, even if the fibula is really nicely present. The important thing about the soft tissue component is to try and release the syndesmosis from behind and to help, to bring the fibula down. It can be done with the help of half pins. We can perform a corticotomy or an osteotomy of the fibula to lengthen and bring it down. One of the risks of doing that is by stretching the fibula at its upper level. It's going to create more of a valgus in the knee joint at a later date. So that's one thing to be taken care of. Second thing is when the fibula comes down to station, as you said, you can use the tightrope to bind the tibia and the fibula together at the new station. What I had done was I put in 2 screws, syndesmotic screws, from posterolateral to anteromedial, engaging both the cortices. So this is articles about tibia lengthening that came from Korea and Japan, in which they found proximal migration. And they found that a single screw is not enough to hold the fibula in position. You have to put in 2 screws. Now, I must admit that in this particular instance, his mother was a little hyperactive and she insisted on screw removal too early. So unfortunately, the fibula migrated again. And, we have to guard against over vigilant parents or those who want to have a say in the treatment. But you're right, very right about your observations. I think the fibular transport is a rare case, and probably a shortening of the tibia is going to help more because it will reduce the overall tension in the ankle joint.
Yeah, one thing I want to say you, whenever we do in valgus cases, the fibula comes downward up to the talus. So what happens is talus is not allowed to do the valgus deformity. So that is our basis of principle. We have done many cases. In these cases that we have bring the fibula after the osteotomy, corticotomy, and bring the downward. So what happens when we reach up to the talus? Talus is not allowed to fibula block it. So there is no need of the screw fixation.
Very, very good. That I agree with you. The other thing is that when the calcaneum is frequently lying parallel to the talus and there is a synostosis in a mal position, the valgus is also partly because of this long lever arm that this synostosed talocalcaneal joint is forcing. So by performing an opening wedge, so it's not sometimes enough to perform an open wedge. So what we have to actually do is do a primary tarsal tunnel release on the medial side, not just do an opening wedge, but we have to shift the calcaneum more medially underneath and then fuse with the help of either screws or temporary K-wires between the talus and the calcaneus and prevent the calcaneum from going into valgus. Very often, even without a stable or a long or a complete fibula at the lower level, there is reasonable stability of the talus within the ankle. And it's the mal position of the calcaneus under the talus. I agree what you're saying is right, but in some instances, the valgus is also created by the position of the calcaneum. And by really getting it down straight, not just by an opening wedge, but also by shifting it medially, the medial calcaneal shift osteotomy, you can prevent the future valgus and keep the ankle stable.
I agree with Dr. Chaudhary. Actually, many times the mal position of the calcaneus, so instead of one below each other, they are sitting side by side.
Correct.
So you have to bring calcaneus below the talus.
Correct.
And that is actually a very important reason of valgus. You have to correct that talus and calcaneus mal position.
Absolutely.
And if need be, you can fuse subtalar joint. Most of the time, there is either bony synostosis or cartilaginous union. So you break it and bring it below.
Correct. So it's a little hairy, you know, when you're doing this surgery, it gets a little, you get your heart in your mouth, because even despite doing the tarsal tunnel release first, when you have to shift the calcaneum medially, you're worried that you're going to press on the neurovascular structures medially. And it's not just enough. In very young children, we could get away, or when the deformity between the talus and the calcaneus is mild, just by an opening wedge, it will do the job in the acinostos. But in older children, the calcaneum lying by the side, you have to bring it down and you have to shift it medially. So that becomes, you know, very worrisome.
Bring it back and translate.
Right. And the tarsal tunnel release, prophylactic tarsal tunnel release is going to really help in preventing difficulties.
I don't know if Dr. Jamal is present with us.
I'm here. I'm just hiding.
Just I have a question for you, Dr. Jamal, concerning the cases. By Zarf, can you do something for the ankle cases in fibular hemimelia and tibial hemimelia? What's your protocol, please?
It depends upon the case. Just if we, my friend Milin, presented fascinating cases. For me, if you have fibular shortening, I do fibular lengthening as a routine. There is no problem with the fibular lengthening, and usually you need it twice, because after 3 or 4 or 5 years, you are going to again to have high fibula because of the differential growth in between. And if you have a vestigial fibula, sometimes you have a vestigial fibula, very small segment of fibula. I just pull it down. But we have to remember something. Apart from magicians in the West, for reality, you don't have a normal ankle. That means the talus is misshapen. So even if you push the fibula down, and in the X-ray, perhaps you have a very nice ankle, but it's not a nice ankle because the talus is not in a normal shape. Usually it's bigger than normal, so the syndesmosis is different. Again, I tell the patient from the start, forget about the magicians in America and this, because they are magicians, they are not, they have superpowers. So remember that you don't have a normal ankle. The talus is not normal, the calcaneus is not normal, and it's even if you have if you push the fibula down, if you do lengthening of the fibula, and the X-ray are beautiful, this is not true, because with growth, I'm sure that the movement of the ankle is not going to be normal, because we always have disparity between the size of the talus and the ankle. It seems like if you have a CDH, and the head is not inside the femur, inside the hip for a few years, if you try to push the head inside, they always have incongruity between the head and the acetabulum. And this is normal, because congruity depends upon the presence of the head in front of the acetabulum. It's the same for the talus. The talus is not in front of the normal ankle. The head is in front of abnormal ankle. So usually the talus takes a misshapen form. So when you push, when you do lengthening of the fibula, which I do as a routine, I don't tell the patient, even if the X-ray looks beautiful, you are not going to have a normal ankle. This is for fibular lengthening. If you have a vestigial fibula, I push it 1 millimeter per day during correction and during lengthening or something like this. It helps to stop the progression of the deformity. Again, it doesn't give you a normal ankle, but it helps in prevention of the continuous progression of the vellus ankle. One point you asked about the epiphysiodesis. In my experience, I've seen epiphysiodesis done abroad in many centers. It never stopped the progression of the deformity. You're going to have, because the people, they have subluxation of the ankle, or during lengthening or whatever, they do arthrodesis of the ankle, and they tell the patient, this will stop the deformity. arthrodesis of the ankle will not stop the deformity. And in almost all the cases that I've seen, I have to do supramallear osteotomy to correct the progression of the deformity. So the third point, even if you do arthrodesis of the ankle, it doesn't mean the end of the valgus ankle problem. So there is no one solution for such a problem.
Thank you very much.
So can I add just one point? So all palate type 3 are usually, ankle is very stiff to begin with. There is absolutely no mobility in the ankle to begin with. So palate type 3, fibular hemimelias, you cannot have ankle movement, mobile ankle. So right from the beginning, they're very stiff. Except for ball and socket ankle and very mild fibular hemimelias type 1, they can have mobile ankle. But type 3, they are very stiff. And expecting normal ankle is very difficult. Right?
So our aim is to blantigrade foot only, not looking for the function of the ankle most of the time. We can't restore, just to restore.
No, we look for the function of the ankle, but we don't have a guarantee. So when we tell the patient we correct the deformity, we simulate a normal ankle. So it doesn't mean at all that you are going to have a normal ankle, because you don't have the components of a normal ankle. We simulate the normal, the anatomical positions, but this is not, you don't have the components of a normal ankle.
Yes, I agree with you. I would just like to share us, when I was doing my post-graduation in Mumbai in 1985, there was a book called Controversies in Orthopedics. I remember this. And there's a story given of whether to reconstruct an ankle which is badly injured and deformed, or whether to perform an arthrodesis. And the one article was written by an orthopedic surgeon who had an ankle arthrodesis on himself. And he wrote, and I remember this now almost 40 years down the line, that an ankle arthrodesis, which is painless, does not cause too much of a disability. An fused ankle, which is painless, can allow a person to do many activities. So we should take hope. Professor Gamal, I agree with you that we can't promise them, but even if they don't have a lot of movement in the ankle, as long as it is not deformed and is not creating deformities in the other joints, we should not worry too much and encourage them to feel that they have achieved a decent result, and not be worried to reach some mythical goal of trying to give a normal ankle when it's not possible.
Yeah, one thing I tell you, in those cases where we have done the fibular lengthening, some years they work. When they become adolescent and other things, it fails always. So we found that for some years the fibular lengthening helped, and after that, due to changes there, it doesn't help. They again develop the vertical deformity.
So I want to ask Professor Gamal, I know very much that your patients are very similar to ours in India, and they never accept an amputation. There's a group in the USA who performed a study in which they tried to perform amputations for fibular hemimelia long ago. This is 15, 20 years ago. I know this is culturally unacceptable for, I think, Egyptian patients and most Indian patients. But still, do you think it has got any merit if you leave aside the culture, just as experienced orthopedic surgeons, if you leave the cultural aspect aside? Do you think that instead of them having, and you leave aside the aspect of the cost of the prosthesis, expensive prosthesis, if you leave that factor aside, if you think that one surgery for an amputation for a really bad, I'm just asking you your opinion, that, and they have one surgery and then they need a prosthesis. And that way they don't have to go through multiple surgery, because all our patients, all my patients also need at least 3 or 4 surgeries during their, growing years. So what is your opinion? What do you think?
Milin, when I started my first fellowship in England with Mike Benson, Mike Benson was was the president of the Bone and Joint and was the president of the European Pediatric Orthopedic Society.
Yes.
And, I was young at the time, and Mike was, if you're patient with tibial or fibular hemimelia, I think within 30 seconds, he usually convinced the family to have amputation before the age 1 year. So the family will accept it as congenital amputation. No one, you know, for almost 6 months asked for a second opinion.
Okay.
They always follow him. They all, no problem at all. And now in my age, you know, just one thing, which is cultural. If he's my son, I wouldn't do an amputation.
Okay.
If it's my leg, I wouldn't do amputation. This is something. But look to the history of medicine. Look to the history of orthopedics. If we remember in congenital pseudoarthrosis tibia, when we were young residents, I'm a bit older than you, and I've learned the lesson when I was a resident. If you have congenital pseudoarthrosis tibia and you have 2 failed surgeries, you have to do an amputation. If the rule now is valid, it's not valid.
It's not, I agree.
If you followed this rule, we wouldn't have this advances in treatment of congenital pseudoarthrosis tibia. So in many cases, you think about it's a long way, but who knows? It looks, you know, hepatitis C, hepatitis C now. Half of my friends died from hepatitis C in Egypt. It was an epidemic. And now the treatment, it just, we don't have hepatitis C anymore because the oral treatment just for 1 month with no side effects, 97% success. So in the history of orthopedics, if we give up for the sake of amputation, we wouldn't have many advances. So it's the same thing for me. I wouldn't surrender for amputation.
No,
so
no,
again,
can I talk?
Yes, sure, Barry.
Only
but
one.
If you agree with me only.
Yes,
if you don't, you don't have to talk.
I must congratulate all the speakers. Very renowned speakers. So, regarding fibula, no question of arising the lengthening of the fibula. Right. When you have fibula, you can lengthen. And very important thing is that you must stabilize the talus and the calcaneum. This is very important in case of fibular hemimelia. The question that was arised different, here, the speakers, regarding the rationale permanently in the tibial hemimelia. MILIND showed his cases. We are not using the rationale because this is not the CPT. And without putting the rationale, you can correct the deformity, procurvatum, or valgus, or varus deformity. Most of the cases you are getting in fibular hemimelia, procurvatum, and the valgus. And regarding the amputation, I have never seen in Kurgan, in CPT, or this kind of here, they have never done this. If you read the literature of Anderson, regarding these 34 cases he has done in his life, and he has done the amputation for CPT. Nowadays, the treatment of the CPT, even then if you go for 2 or 3 times surgery, you will get a very good, fantastic result. So this is my comment. Thank you very much.
Yeah, I mean, I agree with you, Professor Bari. It's very germane comment. But the rationale is not for the deformity correction. I just showed it at the end of lengthening in all congenital lengthenings. At the end of the lengthening, you have to protect the regenerate bone because they have a tendency for a refracture at the lengthening side. So it's just for that sake, not for correcting the deformity.
Okay. Thank you.
Thank you, sir. We had a great discussion, and we have one more presentation to go. Shamsul, let's start with the last one.
Yeah, thank you, sir. Thanks a lot, sir. Thanks, Milind, sir, for a wonderful talk, sir. Next, last, we have our Honorable Professor Dr. OMER AR BARAWI sir from Iraq. Is an FICMS Orthopedics MDA from Netherlands, in consultant orthopedist. He's at the College of Medicine, University of Slemani, Kurdistan, Regional Government of Iraq. He is supervisor of Iraqi and Kurdistan boards for medical specialties in orthopedics. He is head of Slemani Center of Orthopedics, Iraqi board for medical specialties. He has special interest and experience in limb reconstruction surgery, correction, limb deformities, and bone length elongation based on principles of Elizaro. His membership of Elizaro, Association of Application of Methods of Elizaro, Asami, and British LLRS, Society British LLRS, and is going to talk on fibular hemimelia. Omer sir, shall I share your talk, sir? Please unmute, sir.
Yes. Is it good?
Yes, sir.
Yes, please. Okay. Yes.
Yes, sir.
Good evening, everyone. Thank you so much for your kind invitation. I will speak about the fibular hemimelia. The majority of the talk are they are told by Professor MILIND. Anyway, I would like to tell you shortly about my experience, how we are treating fibular hemimelia in Slemani city. Next slide, please. If we are directly going to the photos of the patient, will be easier for the sake of time consuming. Photos of the patient, please. I don't want to take time regarding the classifications. Recently, I am depending on the classification by the PALI, which is treatment-oriented classification. Can you show us the first photo of the patient, please? Next one, please. Next. Okay. These are, as you know, that fibular hemimelia really, it's a spectrum. It's a spectrum. It may associate with other anomalies, especially in the femur, in the tibia, ankle, and foot, even sometimes in the heart, in the kidney, even in the radius and ulna. Yes, please. Show us figure number 1, please. The patient. These are the different classifications, as I told you, but the best one recently I am depending on it is PALI classification, which is treatment oriented. Unlike the other classifications. Yes. Photograph number 1, please. Yes, this is one of my patients, really. You can see that complete absence of the fibula. What I did for this, at that time, before 2014, I was doing reconstruction of the ankle and foot using the unlatch of the fibula as a buttress. But in some of the cases, there was chance of recurrence. Next slide, please. Next photograph, please. Go to the next, please. Why? Yes, now we can see that the limb is equalized, but I'm advising such patient to do follow-up till skeletal maturity. There is chance of limb discrepancy, even sometimes recurrence of the ankle and foot deformity if I'm using the previous methods. But nowadays, for the last 3 to 4 years, I'm using shortest procedure by PALI. Next case, please. Yes, this after equalization, but you can see that there is some sort of recurrence of the valgus, ankle, and foot. Next one, please. This case came to me, amputation done by someone who was complaining from valgus knee. So the prosthesis was not suitable for him. What I did for this case, I did supracondylar femoral hemicalotasis in order to bring the femur into the center. Next slide, please. Now the patient can, this is pre-operatively, even including the hip scanogram. Next slide, please. We can see that there is good consolidated supracondylar femoral hemicalotasis, which is good for application of the prosthesis. Next slide, please. Another case, amputation done in one side, the other side, which I did for him, I did some sort of reconstruction of the ankle and foot and doing some bone elongation. Next one, please. Next slide. We did elongation about 8 centimeters for this case. Now the patient is happy when there is equalization of the limb. Next slide, please. This is simple type of the fibular hemimelia. The only finding is that there is shortening of the right leg, while the ankle and foot is stable. According to the Paley classification, this is type 1. So in such case, they need just elongation, which is known as simple elongation of the leg. Next slide, please. Next, please. I want to go to the photos of the patient. Yes, this case was complaining just from shortening of the femur 7 centimeters. Again, fibular hemimelia. Next. So cooperation of the patient and motivation of the family is very important point is in doing reconstruction of the limb. As we know that patient selection and patient satisfaction are two important factors for successful reconstruction of the limb. So this patient was very cooperative. Next one, please. Yes, we can see that through single stitch incision, we did corticotomy based on the principles of Elizarov. Also, although I am using hybrid type of the frame in which a combination of the wire and pins. Next one, please. Next photo. Yes, now the limb is equalized. The patient is waiting for removal of the frame. After removal of the frame, also I am using brace till I'm sure that there is very rigid corticalization and no more chance of any fracturing. Next slide, please. Yes, next photo. This is with the brace. Next photo. Yes, we can see just by this simple radiograph, we can decide this is a case of fibular hemimelia, in which the head of the fibula on the affected side is not at the same level of the sound side. Next one, please. Next, please. This is well corticalized femur after doing elongation 7 centimeters. Next photo, please. Yes, this is another case according to the Birch classification. We can see just there are 2 digits. According to the previous classification, this was indication for amputation. But recently, in 2014, when Paley he did his publication for shorted procedure, it means shortening distal osteotomy of the tibia and realignment. There is no need for amputation. What I am doing now for the last 5 years, I am doing shorted procedure. Next slide, please. Next, yes, we can see that the ankle. Next one, please. Yes, we can see after shorted procedure, well-aligned ankle and foot, and the patient is waiting for bone elongation. As I told you, in such cases, they need follow-up till skeletal maturity. Next one, please. Another case in which I did shorted procedure for hair. Next one, please. Yes, next one, please. Similar to the previous one. Yes, the same thing. Shorted procedure by Paley. Next one, please. Yes, well, plantigrade foot, but there is shortening, which can be easily equalized by bone elongation based on principles of Elizarov. Next one, please. Next, please. Next. Okay. I want to, after that, I have a case really. Dr. Shams, I think my case is not there. Anyway, because I have a case really, when the patient was 1 year old, I did reconstruction of the ankle and foot. Then I did elongation of the femur 8 centimeters and elongation of the tibia 5 centimeters. Now the patient is waiting for the last elongation. The patient is 17 years old. What is in my mind is to send her for MRI of the knee, but in spite of that, I am doing arthrodesis of the knee and I am doing elongation of the entire limb. It means the femur and the tibia, because before now, Professor MILIND, thankfully, he told his experience that even if we are doing reconstruction of the cruciate ligament, there is high chance of instability. Thank you so much. That was my presentation, but unfortunately, the last photograph of my patient is not with Dr. Shams, although I sent him. Okay.
Excellent. Congratulations.
Thank you so much. Thank you so much.
Plantigrade foot results are really nice.
Really thank you so much.
Yeah. Excellent.
Thank you, sir, for the presentation. And Shamsul, any questions?
No question, sir. No question, sir.
Okay.
Professor Shams, I will send you the photograph later on of my last patient, which is waiting for the last elongation. Now she is 17 years old. I sent you, but I'm sure that you lost it. Anyway, you are busy. Thank you so much.
Thank you, sir, for the wonderful presentation and the wonderful results. And
maybe I have a question.
Yeah.
A note. Thank you all, and it's very nice time to share my friends and colleagues, Professors GAMAL, MILIND, Shamsul, Rajat, also RUTA, all you are friends, Shamsul, Barry. It's a very nice cocktail of elegant friends.
Muhammad Sharif.
Muhammad Sharif. Muhammad Sharif. Many.
Omar from Kurdistan.
Sinha.
Thank you.
Actually, a very nice collection. Just a word, I didn't like to interrupt because I am enjoying with you all and listening carefully for all what had been mentioned. Just a question is, first is a note, is you would like Omar to do arthrodesis knee?
In my last case, yes, please.
Yes, okay, anyhow, arthrodesis knee just attract my thinking. Why? Yes. It is serious to do this.
I will tell you.
In any life.
Yes, excuse me. My last case, which is not present in the PowerPoint, now she is 17 years old. When she was 1 year old, I did back reconstruction of ankle. At that time, I was using enlarge of the fibula as a buttress. Then I did 8 centimeter elongation of the femur, 7 centimeter of the tibia. During elongation, she developed dislocation of the knee, which is something expected because of the congenital absence of the cruciate. Now, the knee is straight, but the only thing is that 15 centimeter shortening in both tibia and femur. I will not do reconstruction of the cruciate ligament, as the experience of Dr. MILIND told us that there's high chance of recurrence of instability of the knee. So the only thing is equalization, which is known as the last equalization, because now the patient is skeletally mature, 17 years old girl. I will send the photos to my great friend Shamsul. He will put it in the site. That's why I am not thinking from any sort of reconstruction of the knee, just re-elongation of the tibia and femur, which is totally 15 centimeter. When I am doing arthrodesis of the knee, I'm sure that about 2 centimeter, again, there will be compression. So my aim is just equalization of the limb with stiff knee. Okay, that is in one of my cases, not all of them. Not all of them.
May I suggest?
Yes, please.
You know the stability of knee, it is not only ligaments and the cruciates.
Yes.
It's also a bony one. Sure, if we put a lower end of the femur with the upper end of the tibia for a long time for a compression, they will have a suitable base between both. What is not happened and not maintained for any reconstruction for a long time to make this chondrification of both ends of the lower end of the femur and the upper end of the tibia. So this is a chondrification, or we can say it as skeletal stability, which is not maintained and which is not take place in many instances in some reconstruction. We're usually looking for the ligaments and the cruciates and what is such as tendon transfer osseous. Didn't look well for the bony. Even if we reconstruct the ligaments or the joints, it is not enough to have stability in both rounded both ends of the femur or the tibia. So this is, in my opinion, it is a sort of importance not to look for ligaments only. This is one. The second is how to compensate 15. You may have, if you'd like, to do what is that had been mentioned ancient, is to make a one limb for this and use the foot and ankle as a knee joint. You can use this, but not that of doing arthrodesis for a long limb to be frequently fractured, and it will disturbs the life of the patient more than we can expect it. This is one. Suppose that one have a long limb and equal limbs, which they are stiff in one bar. It is not amenable even mentally or psychologically or by any way. If even we do it in some sort of physiological, maybe not completely extended. So why not of thinking for doing a custom-made orthosis, for example, for a long time? Why not? And keep ourselves waiting for something to do it, because it is so serious to have a long limb without joints.
I agree.
This is my okay.
Can I add, Professor Fadel?
This is why what drag or attack me to just to talk. Okay.
Professor Fadel, can I talk? Can I talk? Only 30 seconds. Hello?
Yes.
Yes, we hear you.
Yes, sir.
Now that was the photo. That was the photo of the patient. This one is the last photo of the patient. Yes.
Okay.
Now she is using shoe raising. Now she is using shoe raising.
So
that one. Yes.
Last photo. Where is the knee? Where is the knee?
That's the photo. Now
where is the knee?
It will come. It will come. It will come. It will come.
No.
Now she is working with shoe raising. But she
Where is the
equalized.
Knee? Where is the knee?
Problem.
Tibia.
And
tibia.
She has some sort of knee pain also.
Where is the tibia? Upper tibia.
In one of the photo.
No, we don't see.
Okay, Professor Omar, I just wanted to.
Yes, that is the knee. That was the knee. Sorry.
Okay.
That and the patient is standing with shoe raising. Yes, you can see the patient is standing with shoe raising, but she is asking for equalization. Also, she has some sort of knee pain. For those two reasons.
I think the X-ray is not so bad,
yes,
Dr. Omar.
Okay. We don't.
Yes,
okay, Barry, continue. Just
Just. I am 100% agree with Professor Fadel. Why? While you are doing knee stiff knee joint, Judeus quadriceps plasty, we are cutting everything. Medial collateral, lateral collateral, even quadriceps, 5-step surgery. Even then patient can bend the knee. Why not that? That's why I'm telling you, you can do that after lengthening.
Yes.
Because she's walking with 8 centimeters shortening. Next time you can do, don't go for arthrodesis. Whenever you are doing Judeus quadriceps plasty, you are cutting medial collateral, lateral collateral, proximal release, PFL, everything. Even the knee is working. Okay?
Can I say one thing, sir? Actually, nowadays, there is a arthroscopic surgeons are there. They do the quadricephaloplasty by arthroscope. Secondly, at present, no tendon transfer is done. They have a sutures to repair the cruciate ligaments. So that gives a very, very good results. And the arthroscopy surgeon do the VY-plasty by arthroscope. So that gives a very, very fantastic results. So at present, in this era, no one likes to do the arthrodesis. The arthroscopy surgeon do a lot of job.
Professor Omar, if I would like to make a comment, Professor Omar.
Yes, please. Yes, please.
Yes, it's
pleasure.
I think I have had 20-25% failure in ACL reconstructions in the 11-12-year-olds.
Yes.
So there's a couple of lessons I have learned I'd like to share with you. It's not that it is impossible to achieve the stability. It's important to get a thick enough diameter of the tendon graft from the IT band, or we may also use a peroneus longus, etc. What I have done now is I've started taking the help of people who are doing the traumatic ACL reconstructions, even though they're not tuned to this method of pediatric correction. So it's possible to achieve good correction with a proper notch plasty that they can achieve easily. Second,
thank you so much.
What I've found is that when we are doing this in CFD, congenital short femur cases, we tend to perform the ACL reconstruction as a part of the super knee at a very early stage. And I have found that these children tend to develop a very good and stable knee and it doesn't fail. But if we wait long enough for the child to become 11 and 12 years of age and put on a lot of weight, where the ACL absence makes the knee joint really unstable and then try to stabilize it, it has probably more difficulties. So now I'm sure I'm going to do ACL reconstructions in fibular hemimelia at a much younger age.
Thank you so much.
It's a good idea that we do at an earlier age, but we should preserve the knee. That is my aim. And my
agree.
Thank you.
Okay. Thank you.
Okay, thank you so much.
Thank you, sir. Professor HOSNY wanted to add a comment.
Yes.
Yes. If you think about arthrodesis knee, remember the indication, you should have almost normal joints in the ankle, in the hip, and on the other side. Any unstable knee is better than arthrodesis knee.
Yes.
This is one point. The second point, if you think about a patient with 15 centimeter leg length discrepancy and a mobile knee, and a patient with equal limbs and stiff knee, who's better? The patient with 15 centimeter shortening and stable knee. When we lengthen the patients and we have problems with the knee, we have a subluxation knee and we have to put the frame and we correct the knee, we always tell the patients with severe deformities, whatever they are, congenital short femur, tibial hemimelia, femoral hemimelia, perhaps you are going to have problems with the knee. And if you have problems with the knee, you are going to lose some of the motion of the knee. But it's very difficult to think that I have to do arthrodesis knee to have stability to do lengthening. And I think all of us talked about this point to Dr. Omar, just because it's for us, you know, just we cannot start with doing knee arthrodesis to do limb length equality. It's very difficult. Perhaps if you don't do it, you have a spontaneous fusion, perhaps with the compressions. I don't know, but I don't know. I know all of you are doing the same sort of stuff, and I think all of you have put their ideas. I think it's just I'm wrapping up what Barry said and Agrawal and Fadel and all of us talk the same thing with trauma, that it's better to keep a mobile knee with shortening than to have an arthrodesis knee with equal limbs.
May I add something? You finished, Gamal? Sorry.
Yes, I finished.
Excuse me, may I add a suggestion? Maybe not understand, or I couldn't explain it well. Van Nys operation, this is historical operation. The aim is to have this foot and ankle or ankle joint as a knee. It is another solution if we would like to have, but the patient should know that it will have a mobile knee but a prosthetic or a prosthesis. The other one, which is nowadays, which is found, is the osteointegration. Osteointegration had been nowadays rose up. I think we last in deformity correction, deformity course in Cairo, Gamal invited him, Munjid and his friends, and maybe Kevin also working in this, doing osteointegration without any haphazards of these complications. This is for thinking if she had the financial support for this. This is just an idea for you.
Yes, Professor. Yes, Professor Fadel. So that means if the science of osseointegration is really going to progress enough for us to do it in younger patients and have foolproof results, because even they have their complications and it's really expensive. then
Yes,
that
sir.
is, I agree. I agree.
Yes, sir.
MILIND, they told me they don't have complications. By chance, I have a meeting in Cyprus. I have a meeting in Cyprus. And one of our Siberian friends presented a case of osseointegration.
Okay.
And he has horrible infection.
Yes.
And he did till he had disarticulation of the hip after osseointegration. So.
I have a question for the panelists, please. For Dr. MILIND or Dr. Barry, the more expert panelists we have here about the stability. Do you, in your experience, do you expect that knee instability happens after if you do elongation first, then you have the first dislocation, then you will try to do stability, or it's more with already done stability operation for the knee, then you do lengthening. Is it the lengthening?
It's a good question, Mohammed.
Yes.
But the problem is the people talk about stability.
Yes.
But what do you mean by stability?
Yeah,
I've read a lot about the treatment. What's unstable knee? And the unstable knee is different from unstable ankle and unstable hip.
Yes.
What are the criteria? If you have a patient with TAR syndrome, thrombocytopenia absent radius syndrome, sometimes the knee looks like a ball and socket.
Yes.
So sometimes you have unstable bony element. It's not just ligamentous problem. And in many congenital deformities, tibial hemimelia, femoral hemimelia, congenital short femur, you have misshapen articular surfaces. It's not the normal. So it's very difficult to say this knee is stable or that knee is unstable. How would you judge it? It's very difficult. Again, I've seen the people, they have strong ideas and they talk, this is stable and this is unstable. And I will do this and I will do that. Magicians, as I've told you. Look to the real world. If you have hundreds of cases, you'll find that you have bony elements. That's why when we talk about stability, it's not the stability adopted by the sports medicine people and the arthroscopy people. Sometimes we talk about two different things. So for us, it's more complicated than the instability, than anterolateral instability, posterolateral corner problem, things like that. Because we have a bony problem. It's not just anterior cruciate deficiency or posterior cruciate deficiency, which had been, discovered by MRI, and people talk how to manage, how to do something like extra-articular, intra-articular. No. It's far more difficult to describe. So it's very difficult to say that I will do stability first because we don't know what stability means or before. So prepare yourself. If you manage cases with congenital longitudinal deficiency that perhaps in one case you think that you have a stable knee, and during lengthening, you are going to have a subluxal knee. Not only this, I have a stable knee. And after lengthening, there was no problem at all. And after 2 weeks, I started to have gradual subluxation of the knee in fibular hemimelia. And I have cases like this. So it's more complicated than just to give sharp decision and sharp answers. That's it.
Yes. So you advise us, all the panelists, to advise us new surgeons, whenever we have cases like this, to consider all of them are better protection for the knee.
The problem, Mohammed, when you get older like me, and you start to think about and you see follow-up for a long time, you are going to have less confidence in yourself.
Right.
And you start to expect more complications.
Yes.
And less results.
Yes.
Because I see cases after 30 years now, 25 years. When I was your age, I was very enthusiastic. And I thought I was a good surgeon, but now I think that I'm less than average surgeon.
Yes.
Because I've seen hundreds of complications. Right? And when I see the people presenting 100% results, because they have animation experience. When you do animation and you draw Mickey Mouse and moving pictures, sure, you have 100% results because you don't have real patients. But if you are in the real world and there are thousands of cases, you have many complications. Prepare yourself, Muhammad.
Yeah.
Yes.
I'm already facing a lot of complications right now.
So, two things. There's a very famous surgeon in India long ago called Professor Dholakia, who famously said, "Nothing shatters confidence like follow-up." But I think your question was very germane. So just like if we have in congenital short femur, we have a sloping acetabulum, and we do a Dega osteotomy before we do the femoral lengthening. I think in the same way, I think the whole idea is crystallizing that even in fibular hemimelia, even though the knee instability doesn't manifest early, before doing the femur lengthening, it's far better to do, I think, the ligamentous reconstruction of the knee with even the mild instability at a tender age, and then go on to perform the femur lengthening. I think that's a thought. So this is very interesting. I'm really enjoying this conversation. Thank you, gentlemen.
Yeah.
Okay.
Yes, sir. You want to say something, Professor Bari?
Yes. Okay. You want to thank?
Yes, sir. Always. So it was. I think after a long time we have seen such a great conservation between all the starters. And for the viewers, I would like to tell one thing, that we all know Professor Milind Chaudhary. We all are fan of him. But those who have not heard the name of Professor GAMAL HOSNY, like I'm a big fan of him. Who
has not heard Professor GAMAL HOSNY?
Sir, actually, the younger persons, they have heard only the name of Dr. Pele and the West, as Professor HOSNY said, the West people. Because he's such a humble person. He doesn't comes in the limelight. Those who know him, like he is one of the gems, and like every word, whatever he says, every article written by him, we all recommend that you take it very seriously. Whatever he says, a single word, it's based on an experience of 35 years, and it's very practical. No packaging, nothing. Very practical, based on experience. So we will really recommend to all the young surgeons out there to read his publications and to read his lectures, to view his lectures, whatever he's saying. So, in fact, we will request Professor HOSNY if he can share some of his articles. We can put it in the group for the young surgeons to read.
Yeah, my pleasure. Because I'm his neighbor. My country is close to his country. I know him well. I know that he is one of the guys who doing things for the others. So when he writes something, he writes it for the benefit of the others, either the patients or the other surgeons. So I really congratulate him. Best regards for him. Allah keep him. Him and Dr. Fadel, also Dr. Barry. Those guys actually doing things for the others, for the sake of the other benefits. Actually, this is true. This is my testimony for them.
May I add something according to Rajat philosophy that appear now? It's very good idea. It's worth talking is to say that many times also working with Professor Gamal as a friend for him, and also as a mentor for me, 10 years in last century and 23 years in the current century. So we met and accept in his clinic and in our hospital OR many friends from all over the world to associate us and associate him as a head of the department for training. And also, it is important to say that Professor MILIND actually accept for his international center many of LRS professional diploma colleagues, and actually accept I think maybe about 6 or 8 colleagues from Egypt in different years every now and then, and returned it back to our area, not in Egypt only, but in Yemen and maybe in other countries I didn't know. But for Egyptians also, we have a contact with him, and we accept also some friends and colleagues, junior colleagues from India and LRS. And nowadays in Egypt, we have one of our colleagues from Nigeria, Dr. Francis. He's working now, and next week he will associate Professor Gamal in his clinic and his operation. So interaction, as Rajat suggests, it is important to make interaction between and cooperation between our countries. And as I saw the photo of Agrawal actually invited also some colleagues with very good fellowship acceptance, and also we are so sorry that we couldn't take this opportunity yet, but maybe next year to be in his hospital. Actually, Barry also did this. Actually, we did between each other, our countries, a very good cooperation, although it is not institutionally or governmental. It is a burden for each of us as a man who is have the spirit of serving our junior staff from all over our similar countries. Thank you, and waiting our cooperation to be more and more, inshallah.
Such a pleasure listening to you, Professor Fadel. Thank you.
Thank you. We still have your photo with our colleagues.
Very smart. Some of them.
Thank you. Smart. They remember you every now and then.
I hope we can have this. It was really a very thought-provoking discussion today. Thank you, Rajat, so much. I really enjoyed meeting great old friends, Professor Fadel, Professor Gamal, as usual, Professor Bari, the age-old friend, and Professor Omar and Mohammed. Such a pleasure. Thank you so much.
Thank you. Thanks, everyone.
Thank you.
Thanks,
everyone.
Thank you for accepting.
Bye-bye. Bye-bye.
Bye-bye.
Thank you.
Okay.
Thank you, everyone.
See you again. Okay. Thank you, Rajat.